interest is I'm basically a pediatric ophthalmologist. Through one way or the other, ended up as being a pediatric anterior segment surgeon. So I do pediatric keratoplasty, pediatric cataract, and pediatric glaucoma. I have no financial interest to disclose for this talk. There's always been a lot about pediatric keratoplasty, but as all the speakers have said, recently, in the last 10 years, the interest has turned to customizing the keratoplasty to the disease process that is present. And in 2007 or 8, we published the first series of pediatric deep anterior lamellar keratoplasty. Now, when I published this, I was at Great Ormond Street Hospital for Children, and many of the children that were being referred to me had mucopolysaccharidoses. This is like the Hurler syndrome, the Hurler-Shea syndrome. Hunters don't get corneal problems. Maritolami get it, and some types of Sanfilippo. The point is that this group that is rare are now surviving longer because of bone marrow transplant and enzyme replacement therapy. So whereas before the corneal disease was not so important because they weren't surviving, now it's becoming important. And these children can have developmental delay. So if you do a penetrating keratoplasty, they sometimes will hit themselves and you end up with the contents of the eye on their cheek. So the whole idea of doing deep anterior lamellar keratoplasty actually came from a parent who said to me, I want my child to see, but I'm very, very scared about doing a penetrating keratoplasty. Can you do anything else? So this, where I've used deep anterior lamellar keratoplasty in children has been in mucopolysaccharidosis, in macular dystrophy in the late teens, and also when there's been stromal scarring, which is not full thickness. So in the published paper that we did, there were 9 patients, 13 eyes, aged from 13 weeks, sorry I lied, I said 6 weeks, 13 weeks to 14 years, 11 months. 5 patients had mucopolysaccharidosis, 3 patients had scarring presumed to be infectious, and 1 patient had keratoconus. And I wanted to show you something very, very important, is the problem with being a pediatric keratoplasty surgeon is not only do you have to be a reasonably competent surgeon, but you then have to manipulate the brain for amblyopia. So if the child gets to you late, no matter how good your surgery, you are not, 1 logmar is 660 or 2200. So I will show you the pictures. These are clear corneas, but I couldn't improve the vision because the patients had been referred to me after 8. So in children, not only do you have to consider the surgery, but you must, actually this is the most important part of my talk, you must consider the amblyopia, and rather than being scared of operating too early, you should be petrified of operating too late. Because we're not brain surgeons, right? We're eye surgeons. And we can do good eye surgery, but if we miss that window of opportunity for amblyopia, it doesn't matter what you do to the eye. So this is just a table showing you the demographics, and if you want to read the paper, it's published. But what I want to show you is the techniques. So I'm going to show you the first case I ever saw, and that was the first case I was faced with. This was the mother who said, can you do anything else? The electroretinogram was normal, the VEP, the flash VEP was normal, but the pattern VEP was reduced because of the opacity. And he'd had a bone marrow transplant. What does that mean? If they've had a bone marrow transplant, it means that when you do surgery, it's unlikely to recur in the graft. So, here's my problem, and I'm going to put this to the panel and the audience. I tried to do a big bubble. I'm going to show you. I couldn't force the air into the stroma. And I couldn't force it because there's so many glycosaminoglycans, the whole thing is packed. And even if you did, do the panel think that would they have enough of a view to know the depth of your needle? Because that was my worry. is how am I going to know the depth of my needle with something that opaque? So it would be interesting in a minute to see what the panel would have, whether they've had experience in similar opacities. So what I did was I used a high-frequency ultrasound, and I defined what I call the trephined cut thickness, this measurement here rather than the thickness of the cornea. And I just did it using the Baron-Hesburg trefine. I did the trefine down. I really hope that these videos are going to work. So this is not a video, it's just showing I put air in the anterior chamber and I can't tell where my depth is. I can't see anything. Okay, we have a problem with the videos. Oh, here we go. Alright, so I measured with the UBM. This is a Baron-Hesburg trefine. Everybody knows how to use them. And I trefined down. And then, of course, I did a manual dissection. So this is the first one that I did. And I did a manual dissection, and it all, looks okay. There's a little bit of stroma there. But at this stage, I am a little bit hesitant to do anything else. I've got a good result. So I decide I will leave it. Now I want to show you something. People talk about interface haze, and it definitely exists. But in this condition, this is the beauty of this condition. This is what I left. Okay? But after about 9 months, look what happened. It started to clear, and not only did that clear, the host started to clear. Why? Because the donor keratocytes, which are normal, started to migrate, and they have the normal enzyme, and they started to clear the glycosaminoglycans from the extracellular matrix. So what I'm saying to you is, if you see a child with mucopolysaccharidosis, or even an older patient with macular dystrophy, because the pathology is the same, don't be afraid if you don't get down to decimase. As long as the systemic treatment has been done, or it's macular dystrophy, the keratocytes from the donor will clear your stroma. So that's a good lesson. And look, this is how he looked after a year. So I left a little bit of stroma, but no interface haze, because this is not an adult. It's a different etiology. So what about the viscodissection? Here's a child who had a scar, and you would think it's not a very big scar, but no matter what I did, I could not improve this child's vision. She was 2 years old, I patched her, I gave glasses, I gave contact lens, nothing would work. So eventually, we agreed, mother and I, that I was going to do a DALK. So this is the viscodissection technique that I use, Mele's technique. There's air in the anterior chamber. I take my needle. As you approach decimase, you get the triple reflex. I'm going to say that again. You get the triple reflex of the point of your needle. And at that point, you know that you're very close to decimase. And then when you inject, initially you get this kind of haze. But then just be confident, keep injecting, and suddenly you see the wave. Now for me, this is so much more controlled. I know where that wave is going. Look at it go. I am peeling off that posterior stroma from decimase. There's my, I don't know why it stopped there, it should be going. The problem? Okay, well, anyway, it went all the way across. Then I do a manual trefine. Can you help me? I'm trying to advance. So what's the next evolution? So I've now started to do the viscodissection even for mucopolysaccharidosis cases. But I want to show you that that technique for me has improved by having the handheld OCT. Now, I'm very lucky that at the University of Pittsburgh, where I work, I have a co-worker called Kira Lathrop, who is a basic scientist in imaging, and she helped me develop this arm that we use. The arm stabilizes the handheld OCT so that you can move it to 0.1 degrees in any direction, up, down, and around, sideways. So with that, look, now this is a MPS case, not so dense, but when you do the visco dissection, look what happens. And then once you take the disease stroma away, there it is your layer, but is that Dua's layer? See that? Definitely 2 layers. But again, took Harminder Dua to notice that. Now here's a case, this was very dense, and normally I wouldn't do it, but I had this machine with me and I said, okay, I'm going to do it. And when I did the visco dissection, look what happened. Disaster. I can't see anything. So I did a manual cut down and I'm left with that. With the OCT, I can see that here I have a pre-decimase visco level, so I was able to cut it and then clear it. So for me, this has made a big difference. And what Praveen was saying, look, even though I've put my sutures in, there is a mismatch present there, but the apposition was excellent. What we are doing now is we are running the OCT simultaneously while I operate and feeding that image into my eyepiece so that I can see the level of my needle. Now, I've only ever done that in cadaver eyes, but when I do it in my first case, I'll definitely put it on YouTube or MyTube or whatever they call it. So, DLK really should be considered in children, and there's a reduced risk of rejection. We have had no rejections in our cases, and it's a very good alternative. If you're interested in discussing adult corneal surgeons discussing pediatric corneal cases, which you all do, then please come to the World Society of Pediatric Ophthalmologists for Business Pediatric Subspecialty Day at ESCRS this year. It's gone off. Why has it gone off? Can you put it back on? I know my time's up, but this is an advert. Thank you. All right? Okay? And this is the big one. Barcelona 2015. We're going to have Eucornea and the World Society having a joint half-day meeting. And the last time we had this, we had 4,000 people in the audience discussing our experiences at cornea. Thank you so much, and please become a member. It's free. Thank you very much indeed. Please come.